Hi and welcome back to another video of Medic Notes. This video is on types of pneumonia, including bronchopneumonia, lobar pneumonia, aspiration pneumonia, and atypical pneumonia. For bronchopneumonia, it occurs chiefly in old age and infancy. Occurs in patients with debilitating disease, such as cancer, cardiac failure, and renal failure. Predisposing factors include COPD and cystic fibrosis. It also occurs in early postoperative period due to failure to remove respiratory tract infections. Causative organisms include Streptococcus pneumoniae, Haemophilus influenzae, and rarer causes include Staph aureus and coliforms. Staphylococcus aureus pneumonia are seen in hospital patients, after influenza, as a severe secondary bacterial pneumonia. Also seen in intravenous drug abusers. And in the immunocompromised, it may be fulminating and rapidly fatal. Coliform bronchopneumonia is rare, may be encountered in hospital patients, the immunocompromised, and those on ventilatory support. Bronchopneumonia is of characteristically patchy distribution and tends to be basal and bilateral. Histological examination reveals inflammatory cells in the bronchi and bronchioles with alveoli filled with inflammatory exudate. Next type is the lobar pneumonia. This is rarely seen in surgical patients. It may result in referred pain to the abdomen, particularly right lower lobar pneumonia. It enters into the differential diagnosis of appendicitis, due to the intercostal nerves being irritated, and pain being referred to the right iliac fossa. It is commonly caused by Strep pneumoniae. It is part of post-splenectomy sepsis, and relatively uncommon in infancy and old age. Clinical features include cough, fever, rusty, sputum, rigors may occur, acute pleuritic chest pain, and consolidation of a lobe or part of lobe. Classically, 4 stages of the disease are recognized pathologically. Congestion lasts about 24 hours and is due to protein-rich exudate filling alveoli, with venous congestion. Red hepatization lasts a few days, with inflammatory cells and red cells in the alveolar spaces. Fibrinous exudate on pleura, lung is red, solid, airless, and bears a resemblance to the cut surface of fresh liver. Third stage is gray hepatization, where there is accumulation of fibrin with the destruction of white cells and red cells, lung appears gray and solid. And last stage, resolution. This occurs in 8 to 10 days, inflammatory cells and fibrin are reabsorbed, and the underlying lung architecture is preserved. The above is a classical pattern of lobar pneumonia. Most cases resolve as above, although the pattern may be modified by early and appropriate antibiotic therapy. Next, for aspiration pneumonia. It occurs when upper gastrointestinal contents are aspirated in lung. Results in consolidation and inflammation. Clinical situations in which this may occur include induction of anesthesia, recovery from anesthesia, sedation, coma, and severe debility. Part of lung affected depends on the patient's posture. Abscess and empyema may result. Causative organisms are usually commensals of the upper respiratory tract, principally Strep pneumoniae, although anaerobes are also involved in the majority of cases. Lastly, for atypical pneumonia, main causative organisms are Mycoplasma pneumoniae, Coxiella burnetii, Chlamydia psittaci, and Chlamydia pneumoniae. Mycoplasma pneumoniae is responsible for most cases of primary atypical pneumonia. School-aged children and young adults are the group most affected. It is spread by droplet infection, and the effective drugs include tetracycline and erythromycin. One of the atypical pneumonia is called as Legionnaires' disease, which is caused by Legionella pneumophila. Patients are typically middle-aged smokers, often in poor general health. May also affect patients who are previously healthy. Spread by water droplets from contaminated air humidifiers or water storage tanks. Symptoms initially those of flu-like illness, which progresses to severe pneumonia and respiratory failure. Other features include headache, mental confusion, myalgia, nausea, vomiting, diarrhea, and acute renal failure. 10 to 20% of cases are fatal. Treatment is usually with erythromycin, but those failing to respond may be treated with rifampicin or ciprofloxacin, either singly or in combination. That's all for this video. Thank you.